Just got to introduce Frank Sullivan. The actual social prescribing of golf is something been very close to my heart for a number of years. We've not quite moved it forward up until now, but we've got a pilot going on in St Andrews. We've got other work going on in other parts of the country, and Frank's going to share some of that stuff with us. Thanks, Frank. Sorry I've taken a little bit more time than I thought.
Thank you, Roger. Yeah. So Jennifer and I are going to speak a little bit how to link primary care to golf schemes, of which there are several about the place. Talk you through where we are with it and where we'd like to go in the longer term. Thank you all for coming to this session, and try not to keep you too long before lunch. Can I just ask before we start, how many people are GPs who are in the room already? Or retired GPs? Several, including Scott here. And how many people work in primary care other than GPs, as nurses, pharmacists, occupational health, etc.? So there's a bit of knowledge about what's going on. Jennifer's going to talk about work that she's done on actual prescribers' views, because that's obviously key when you're designing anything. I'll talk a bit more about another project which is linking in with that, which has had quite a lot of support from the RNA and from a number of other bodies, which I should have quickly shown you all the logos before we started, so that nobody feels left out. But anyway, I probably don't need to say anything about this slide, because actually, although I'm mainly worried about being eaten by a shark, everybody who's here knows that physical inactivity is much more of an issue. You wouldn't be here. But can primary care do something about it? That's really the question that we're trying to come to, is the opportunity where people who are thinking about something else come and consult, or they get a letter, or they're attending for some reason. Can they be prompted towards going to consider starting up with golf? And so we're going to talk about how we might do that, and I'm going to pass over to Jennifer now.
Is this mic on? Hello. Hi, thanks for the introduction, Frank, and thanks for having me to speak today. I just want to give you a brief overview of a project that I have done as part of my Masters in Physical Activity Health here in Edinburgh. So thanks to the RNA and the European Tour for helping support this project, which was really an exploratory project looking at primary care practitioners' knowledge of golf and health. And I just want to give you a brief overview. There is a poster downstairs if anyone has any further questions on this. So essentially, I conducted a study, which was an online survey, and I managed to recruit 100 primary care practitioners. So this includes not just GPs, but other people in the primary care setting that can prescribe, such as advanced nurse practitioners, physiotherapists, and nurses. And there was an 83% response rate. And just kind of jumping to the results, really, as I think this is the most important point that we can take from the exploratory study, is that of those that completed the study, 18% were regular golfers. So you did not need to be a golfer to take part in this scoping review of people's opinions. Roughly half and half, males and females, and 83% were GPs themselves or GP trainees. So interestingly, as many people in this room probably agree with, over 80% of the respondents thought that golf was beneficial for both their physical and mental health. However, only 28% were likely to prescribe golf, and this was in comparison with 70% of them who were likely to prescribe physical activity. So really it gets us thinking, why is there such a gap between the difference in prescribing physical activity in golf? And a lot of that has been discussed at this conference, and hopefully making moves in how to try and break down that difference. So in this survey that was shared over a month, there was further exploration in the facilitators and the barriers to the primary care practitioners. And 8 themes were identified that help facilitate prescribing golf in primary care. And they're outlined here. And just to give a couple of examples of some paraphrasing, so for example, in relation to the knowledge and resources, primary care practitioners would like more resources and feel that if they could share this with their patients, that would help facilitate the prescribing of golf. Cost is a big one. We've spoken a lot about that in this conference. And is there funding there for prescribing golf and having that as a formal referral scheme? And another really important one to highlight is evidence about the benefits. We in this room know a lot about the evidence of the benefits behind prescribing physical activity in golf, but really we want proof in the pudding to be able to say to our patients, this is an example of the benefits of playing golf and how it is good for your physical, mental and social health. Moving on to the barriers, unfortunately, yes, there are barriers to prescribing golf in primary care, and the main one was a lack of resources. But additionally to that, they wanted a better scheme, a better physical activity referral scheme, and also money. Funding is a big barrier in primary care. But overall, respondents thought that the best way to provide information on physical activity referral schemes is leaflets, face-to-face, or a dedicated website. And I feel that by being here at this conference today, that is acknowledging the face-to-face element here, which is great. And the GPs, those in the primary care practice, would prefer to promote this scheme alongside a formal referral scheme, which is what Frank will go on to talk about, and about some other research that we've got in the background. So thank you.
Thanks, Jennifer. So the work that she's done really follows on to what we were talking about. We got into this because there was already work going on in the department doing a review about how to make connection for any sport. And this is the paper that went through all the normal ways of identifying papers in the world literature and was published in Health and Social Care. Obviously, policy documents came up quite a lot of those, including NICE recommending the opportunistic contact whenever people come anyway into contact with health professionals. That is an opportunity to make the referrals, but there was very little evaluation on how it worked. It's often the way when you get started in an area, you find lots of descriptive papers, but nobody actually following up large numbers over time to see what happened. What Catherine Cunningham, who led this work, worked out that there was really a total of 7 different ways of making connections that were described. The one at the top here, the direct route, where a nurse at a diabetic clinic or a GP seeing somebody who's maybe for a cardiovascular review says, actually, you could be taking more exercise and makes a direct referral to the physical activity opportunity. But there's a whole load of intermediate ways around that, about the length of signposting, whether it's just literally notes up in the waiting room, or whether it's another side of people's prescriptions saying this is something that we're doing, to actual writing prescriptions, like in these exercise referral pads. So there was lots of different ways potentially to do it. And I was speaking to colleagues in the RNA around the time that this was published, and we came up with this idea of having a project called EAGLE. We did have to torture the English language somewhat to get it into some kind of golf metaphor, where we develop the golf packages with the local golf clubs and then work on the connection pathways. And that's really what we did. The first part used this standard the design method that's used in lots of developing services, discovering and defining what's to be done, and then developing it further before you go on to deliver. So there's a set way of doing all of that, which we did. COVID intervened, so instead of having everybody in a big room like this and having post-it notes all up over the wall, it was all done kind of electronically, but there were some tools that were available to allow that to happen. And basically along the top here just shows you how you go from somebody who might be somebody who would benefit from getting more exercise, including golf, to actually starting to play. So we're doing the work, if you like, at 2 levels. One is within primary care, another one was with the golf clubs. And this is the initial findings that we had, that actually number 3 in this list, community link workers, social prescribing facilitators, they've got a number of names, but there's already people working in primary care to whom clinical staff refer to say, you might benefit from sitting down with this person and seeing what opportunities there are locally. So that's a mechanism which is already in existence. and that we would work with them and also with people working in the practices to work out the pathways. What we developed with the clubs was the idea of once you've got around 6 or 8 people in an area to be referred, they would get a taster session. They would then get 8 weekly sessions led by a professional. They would have a buddy assigned, getting over some of the issues that we've heard about, people maybe being a bit diffident or uncertain about going, and also social events, making that it's, yes, there are the 9 or 18 holes of golf that they're starting with, but actually there's a whole lot more to joining in with the golf club. This is where we are at the moment. We've got 7 practices, 3 of the community link workers and 6 golf clubs now, just in Fife, and we've mainly focused on the clubs that are in the more deprived areas, and we're trying to get 60 patients initially to get some experience of it. The inclusion criteria are people who are new to golf, so it's not returners, and people who are taking less than the recommended amount of exercise in a week. Now, exclusion criteria, I've left a blank here because whenever we actually started looking at the literature on this, it was, well, we're not really sure. Yeah, obviously, if you had a heart attack last week, you probably aren't able to go and play a whole round of golf. But actually, as long as somebody can walk about a mile and their dementia isn't sufficiently severe for them to wander off, then probably almost everybody can be included in this, and it's one of the things that we're testing and looking again at what the exclusion criteria should be. So the research questions in this Eagle 2, if you like, is acceptable to all of the stakeholders, the practices, the link workers, the golf scheme. How well can it be implemented? What proportion of the stakeholders actually engage? We've heard already that practices are very keen. I would say they're super keen. Anytime I've phoned up any of the practices to say, we're starting this in your area, your golf club nearby is interested, are you interested? They've been all holding me back. This is what we want. They want the kind of mechanisms to make it straightforward to do. And we want to look at what benefits patients are getting. We've heard lots of that in the conference about how that can be measured. The evaluation will be both qualitative with questionnaires, interviews, focus groups, but we'll also start to pilot some of the more quantitative methods of counting up how often people go, what physical benefits that they're getting. And again, at the conference, I've picked up several ways that people are already doing that we might adopt once we've got past this pilot. Because this is the last slide. When we're finished with this phase 2, we want to optimize, want to learn from what we're doing over the course of the autumn, and then go to the public health strand of the National Institute for Health Care and Research to say this is something which could be benefiting an awful lot of people. This is what we've learned in Jennifer's study and in the ones that we're doing about how to make it work. And let's get serious about rolling this out, not just in the wee project that we're doing just now in Fife, but probably across the UK, working with other colleagues here over the last couple of days. And that's what we're aiming to do. And I hope you'll share that ambition, and we'll be contacting various members here to help to take it on. Thanks very much. So I think we're open for questions now. Yeah, one at the back and then one over here.
Thanks very much. That was really interesting. I just wondered how the costing or the economic balance of who was paying for what was working out for you between the clubs and the primary health care.
I'm not sure we've got a good answer to that at the moment. We've had funding from the RNA and from HANDA to pay for whatever costs that we're incurring. And we will be adding in an economic appraisal to work it out. I mean, all these things, when it comes to economics, is what do you count? How wide do you go on this? What assumptions do you make? So we are working with some card-carrying health economists to help on that. But I'd be for probably taking, as we heard in the Finnish study this morning, about taking quite a broad view, not just how much do we have to pay the golf professionals to make it worth their time to run sessions and organise the buddies and everything, but also the wider benefits.
Thank you very much.
I think Frank and Jennifer will be around for the rest of the day. Yes? So perhaps we could ask other questions. And this is a burning question. We perhaps ask questions. Sorry, someone here? Chris.
Frank, we talked about this very personally yesterday. We know the key person in the National Exercise on Referral scheme that already exists is actually the triager that sets up the exercise programs in the leisure centres. And to me it seems that we mustn't overcomplicate this. It's perhaps better to include them in the real education phase so that they've got more quivers to apply to their bow, if you like. And that we all know that all of us who are practitioners here, we like the idea of extra activity for our patients, and the prescription of that activity is great. But actually people who spend more time with the patients have that time, can better assess whether golf would be a good idea, or archery, or fishing, or a bit in the gym. And so that's going to be the key. And of course the question that you've just been asked, which is the most difficult one, is central government going to stump up the cash that adds this arrow to that really excellent quiver? And we're all beginning to develop the information that shows that golf is a worthy arrow to be in that quiver.
Okay, I think we better move on now. But thanks ever so much, Frank and Jennifer. Thank you.